Welcome to this essential guide on understanding and managing intrauterine growth restriction. As a woman or a healthcare professional, it's crucial to be informed about intrauterine growth restriction. Today we will explore the definition, etiology, risk factors, clinical features, differential diagnosis, investigations, management, and complications of intrauterine growth restriction. Intrauterine growth restriction, IUGR, also known as foetal growth restriction, FGR, is when a fetus does not grow to its genetic potential in the uterus. IUGR is associated with an increased risk of morbidity and mortality. The terms IUGR and small for gestational age, SGA, are often incorrectly used synonymously. SGA is defined as any fetus with a fetal abdominal circumference, AC, or estimated fetal weight, W, less than the 10th centile for its gestational age. The fetus may be constitutionally small without being at increased risk of complications. In contrast, IUGR is a pathological in utero growth restriction with an increased risk of fetal compromise. Asymmetrical IUGR refers to disproportionate growth restriction with a greater decrease in fetal body and limbs compared to head circumference. It is caused by extrinsic factors such as placental insufficiency. In asymmetrical IUGR, oxygen and nutrients are directed towards vital fetal organs, brain and heart, bypassing other organs, liver, muscle, and fat tissue. This affects the fetus in gestation. Symmetrical IUGR refers to proportional growth restriction in all parts of the fetus. It is caused by intrinsic factors such as genetic abnormalities and intrauterine infections. This affects the fetus early in gestation. Risk factors for IUGR can be divided into maternal, uteroplacental, and fetal risk factors. Maternal risk factors include maternal medical conditions, pre-existing diabetes mellitus, chronic hypertension, gestational hypertension, preeclampsia, systemic lupus erythematosus, antiphospholipid syndrome, sickle cell disease, severe anemia, anorexia nervosa. Substance use, tobacco, alcohol, cocaine, or narcotics. Exposure to teratogenic drugs, ACE inhibitors, warfarin, carbamazepine, phenytoin, cyclophosphamide, or valproic acid. Previous pregnancy with IUGR. Uteroplacental risk factors include placental insufficiency caused by maternal conditions, e.g. chronic hypertension, diabetes mellitus, sickle cell disease, or anorexia nervosa, or pregnancy-related conditions, e.g. Rh incompatibility or preeclampsia. Placenta previa or placental abruption. Umbilical artery thrombosis or infarction. Uterine abnormalities, e.g. fibroids, multiple gestation. Fetal risk factors include congenital early intrauterine infections, toxoplasmosis, rubella, cytomegalovirus infection, varicella, tuberculosis, herpes infections, HIV infection, syphilis, or malaria. Genetic abnormalities, aneuploidy. Congenital anomalies, tracheoesophageal fistula, cyanotic congenital heart disease, gastroschisis, or neural tube defects. A thorough obstetric history is crucial to identify any risk factors for IUGR. Signs and symptoms will depend on the underlying cause of IUGR. For example, a patient may present with abdominal pain due to placental abruption or headache, visual disturbances, and epigastric pain due to preeclampsia. Typical clinical findings in suspected IUGR include symphysial fundal height, SFH, is decreased compared to gestational age, at least 3 centimeters less than gestational age in weeks. Fetus is small for gestational age. Fetal movements are reduced or absent. Relevant bedside investigations include maternal vital signs, basic observations, blood pressure, heart rate, respiratory rate, oxygen saturation, temperature. Urine dipstick. Cardiotocography, CTG, to assess fetal compromise. It may show late decelerations of the fetal heart rate and fetal bradycardia in IUGR. Appropriate laboratory investigations are performed based on the suspected underlying cause of IUGR. For example, oral glucose tolerance test, OGTT, for gestational diabetes mellitus and serological screening for congenital intrauterine infections. Relevant imaging investigations include serial ultrasound scans to assess fetal biometry and estimated fetal weight, which are plotted on a customized growth chart. Ultrasound also provides detailed information on fetal anatomy, placental morphology, and amniotic fluid volume. Findings may include decreased fetal growth with fetal weight below the 10th centile of a given gestational age, small placenta and oligohydramnios. Umbilical artery Doppler, UA Doppler, shows abnormalities such as reduced or reverse diastolic flow. Biophysical profile, BPP, is a non-invasive test that integrates different parameters to assess fetal well-being. Typical findings in IUGR include amniotic fluid measurement of 5 oligohydramnios, absent fetal breathing movements, and decreased fetal movements in tone. A BPP score of 4 indicates the need for delivery. The diagnosis of IUGR is made from serial ultrasound scans and umbilical artery Doppler, UA Doppler, showing estimated fetal weight 10th centile, oligohydramnios, abnormal UA Doppler, and/or poor interval growth velocity and/or EFW 3rd centile. Conservative management involves optimizing modifiable risk factors during pregnancy, including smoking cessation, drug counseling, and healthy diet and exercise. It is important to treat any underlying maternal condition, e.g., treatment of gestational diabetes mellitus or preeclampsia, and medically optimize any comorbidities before and during pregnancy. Maternal vital signs should be closely monitored alongside fetal status. Delivery should be performed if there are signs indicating non-reassuring fetal status or maternal compromise. The optimal timing and mode of delivery, either induction of labor or cesarean section, for IUGR require careful consideration of both maternal and fetal risks of continued intrauterine existence, premature delivery, labor, and cesarean section. The goal is to delay delivery and prolong intrauterine life to gain fetal maturity, improve survival, and reduce the risks of morbidity and mortality. Induction of labor is offered to all patients. However, a cesarean section is strongly recommended when there are signs of fetal compromise, such as absent and reduced end-diastolic flow F in the umbilical artery. Magnesium sulfate should be administered in gestations less than 33 plus 6 weeks for fetal neural protection, where delivery is contemplated. Prenatal corticosteroids should be administered to women with IUGR fetus between 24 plus 0 to 33 plus 6 weeks gestation when preterm birth is imminent. Corticosteroids should be discussed with women undergoing a planned cesarean section up until 38 plus 0 weeks. When EFW is 10th centile and UA Doppler is normal, delivery can be delayed until at least 37 weeks and even until 38 to 39 weeks of gestation in some cases. The risk of a recurrent IUGR in a subsequent pregnancy is approximately 25%. Preventative strategies for IUGR include reviewing and managing the underlying causes, e.g., maternal comorbidities, lifestyle advice such as smoking cessation, and dietary advice. Consider administration of low-dose aspirin prior to 16 weeks of gestation. Complications of IUGR include preterm labor and delivery, stillbirth, perinatal asphyxia, necrotizing enterocolitis, cognitive delay and behavioral issues, adult-onset diseases e.g. diabetes mellitus, obesity, coronary artery disease, hypertension, motor and neurological disabilities, intrauterine neonatal death. Thank you for joining us in this educational journey on understanding intrauterine growth restriction. Stay informed and take proactive steps to safeguard your health.